Hi everyone, it's Olivia, and as you may have guessed, today I'm going to be talking a little bit about agitation and aggression and behavioural strategies. So, agitation and aggression in dementia is a huge topic. I could speak for hours and hours and hours on it, but and so I don't bore the pants off you all, what I'm going to be doing today is giving you a whistle stop tour around some practical strategies that may be useful in managing agitation and aggression in FTD and other rare forms of dementia. So, although I might be touching on FTD quite a lot today, all the strategies which I'm going to be talking about will be relevant to other forms of dementia. Okay. So, yes, non medication approaches to the management of behavioural symptoms. So, the strategies which I'm going to be discussing today are according to the caused assessment and problem solving model, which is a really neat little anagram that we can use to look at somebody's behaviour and think why it could be happening, and therefore what we could do to potentially manage that behaviour, and to emphasize that these suggestions are not an exhaustive list. The symptoms experienced by individuals living with dementia are highly variable, regardless of their diagnostic subtype. Similar symptoms in different individuals may require a completely different management style, and of course, not every strategy will work for every affected individual, and not every strategy will work every time it is applied. So sometimes we need to individually tailor responses and also do a bit of trial and error to see what works best for us as caregivers and our loved ones living with dementia. Okay. So, the first thing that I want to highlight is that many behavioral and psychological symptoms of dementia are actually triggered by so the caregiver's approach and their attitude towards the person with dementia in a given scenario. So, agitation and aggression are more likely when caregivers have unrealistic expectations of the person, or when the care delivery or strategies are not tailored to their preferences, their abilities, or their strengths. But first of all, I wanted to show you, as you guys are the experts, people living at home with somebody with a diagnosis of rare dementia. And what I'd like to do is just briefly go through some of the amazing things which I've been taught from our members. So, the first thing there, don't try to reason with your loved one if he or she is unable to do so. I think that's incredibly important, particularly with FTD, as the part of the brain that deals with reasoning is affected by FTD. So, it's not a great strategy to try and reason in these situations. Another quote, and I really love this one: choose your battles. And we're going to come back to that in a little bit. Modify your own expectations rather than expecting the person to be the way that he or she was. Acceptance is slow, but it's the key to setting you free. And finally, if the person is frustrated by communication difficulties, avoid placing them in situations which communication is heavily relied upon, such as phone calls, group daycare, or large social gatherings. So maybe think, if the communication is causing frustration and agitation and aggression, maybe have a think about that dinner party, have a think about that phone call, that daycare setting. Lovely. So, some people living with dementia can have difficulties controlling their responses or impulses, even when their behavior might not be within social conventions, lawful boundaries, or it might be hurtful to themselves or other people. Now, disinhibition and impulsivity can often present as outbursts of aggression and irritability, which we're going to talk about today. So, this simple acronym can help us think about all the confounding factors that may have caused a person's symptoms and behavior, and what possible strategies we can do to try and help. So, first of all, we have C, so communication. Does the person understand what is expected of him or her? A, for activity. For example, is the person overstimulated, or equally, are they bored? Does the assistance which we provide or the task itself enable or disable the person? U for unwell. Is the person depressed? Are they in pain? Or are they simply uncomfortable? And this is something which we often think about, which we often forget to think about, sorry, when thinking about agitation and aggression in dementia, because sometimes we think that it must be due to the dementia when actually there could be something else happening organically. Story. S for story. Who is this person? What were his or her interests, habits, former occupation, significant life events, culture, or attitudes? And how likely are these things to influence their behavior? E for environment. So, are there any physical obstacles? Is there noise? Is there unfamiliarity? Are there other aspects of the environment that are either enabling that person or disabling them? And finally, D for dementia. What are the person's cognitive disabilities? What are their retained abilities? And how might this be affecting them? So, this caused acronym can be really, really helpful when thinking about aggressive and agitated behaviours. And we're going to come on to a few examples. And these are examples of situations which I've talked through with family members and carers who've come through rare dementia support. So, some nice, real examples today. So, example number one. My husband has a diagnosis of FTD. He started swearing, shouting, laughing loudly at inappropriate times, belching, making crude comments. He previously never did this. Okay. So, looking at this particular behaviour, what potential strategies can we use? And we're focusing on that C for communication here. So, you could try using firm but kind limit setting behaviour to redirect from this behaviour that's happening. Humour might often help soften this limit setting and reduce the risk of eliciting a defensive response. So, for example, um, if somebody made a crude comment, instead of saying, Dad, that is disgusting, this won't be tolerated, oh, that's awful. You could try saying something like, now, Dad, you're going to get us in trouble with the swear police. Or maybe use something like a swear jar to collect fines for swearing to reinforce this limit setting. But of course, this might not help everybody. Example number two. My wife often responds aggressively to responses to communication and sometimes limit setting. So in this case, the limit setting actually hasn't worked and it's actually potentially aggravated this behavior. So what can we do? Avoid trying to rationalize with this person, as I mentioned previously. Do try to remain calm and don't respond with anger or frustration. And I understand how difficult this can be. Don't try to persevere if the communication or request is triggering aggression. You can always leave that conversation, do something else, and come back to it later if necessary. But try not to persevere if the communication is triggering aggression. And you could also try changing tactics to empathize with their frustration and ask how you can help. So instead of telling somebody to stop and trying to rationalize their anger or agitation, you could say something like, I can see that this is really upsetting you. I can see that you're getting frustrated there. Can I help in any way? Can I do something? What can I do to make this situation better? So moving on to A from our acronym for activity. This example here, mum has been diagnosed with dementia for a few years now. She often has aggressive outbursts and aggressive behaviour towards myself and carers. Okay. So, possible strategies in this situation. Is mum frustrated by her inability to respond to an activity request? And if so, can we adjust the communication? It's really important to think about matching tasks and activities to a person's strength to avoid frustration and potentially triggering aggression. Another thing to think about is this activity actually necessary? And people come to the direct support team a lot with questions around showering and bathing, and that these particular activities can trigger aggressive or agitated responses. And my first thing is it very necessary that that person is showering or bathing every single day? And quite a lot of the time, it's absolutely not necessary that that person is having a bath, having a shower every single day. And how can we make that activity or modify that activity to make it easier or less intrusive in order to reduce the triggers for aggression? So in terms of bathing, it could be about making it a really luxurious experience, having some music playing, having some really nice scented body lotion or oils, and shower gels. Um, Using touch can often be helpful. So helping with that bath time routine and making it a really lovely experience. Or equally, it's sometimes thinking about a meaningful event which happens. So, for example, if somebody really values seeing their grandchildren or a friend, you could set it up and so that they are bathing because their grandchildren are coming around, and therefore it is a reason and a nice reason to be getting a shower or a bath. And just some tips here on safety. So do try and maintain a safe distance or think about your body position during activities, and have an exit strategy or escape plan worked out. And this is particularly important if your loved one sometimes can have aggressive outbursts. They might pull hair, they might grab clothing, they might lash out. Thinking about your body position and thinking about positioning yourself near an exit so that if they were to respond aggressively, that you can safely get away rather than you having to move the person or get around the person to become free of that. And very important, if you notice that aggression is escalating or agitating is escalating, withdraw from that person and try again later if it's safe to do so. So, by all means, if it is becoming more and more and more aggressive, stop, and you can come back to it later. But as I said, if you're able to do this, okay. So again, another example from activity, so the A of our caused acronym. There's been an increase in my brother's symptoms of agitation. He has a diagnosis of PPA. So thinking about possible strategies for agitation. So agitation, people can sometimes get very agitated if they're bored, if they're understimulated. Can that person be given a meaningful activity or task which is suitable for their abilities? And also, could physical exercise assist in diffusing agitation? So having a walk, doing something like that, or doing a meaningful activity, could that help with symptoms of agitation? So moving on to U of our caused acronym is for unwell. And the example I'm giving here is Dad has been behaving more aggressively. He's been going to the bathroom more frequently and is complaining of pain. So I'm not a medical doctor, but that sounds very suspect to me of a UTI or a urinary tract infection. And it's really important to remember that an acute increase in agitation or aggression, increased wandering, tearfulness, complaints of pain could be a sign of an acute illness or a delirium. It's really important to rule out or seek treatment for reversible causes and try to anticipate unmet needs that may be driving this behaviour, such as an infection, pain or boredom. And this is really important to note, because sometimes people living with dementia might have difficulties expressing that they are in pain or that they aren't feeling unwell. So having a chat with your GP and seeing if there's anything which is organic, which can be reversible there. Okay, so S for story. Does life history indicate a history of aggression as a stress reaction or defense mechanism? So, if a person has a history of maybe anger management difficulties, jealousy, or maybe that they would respond with violence, they're more likely to react with anger when frustrated as their dementia progresses, especially as they become more disinhibited and less able to control impulses. In this situation, we should be asking, how was this managed before? So if this is a long-standing behavior, how did that person manage it before? Was it a case that they had some time by themselves? Did they listen to music? Did they go out for a walk to diffuse that anger? What did the person or others do to reduce the triggers and escalation previously? And these answers should help us inform potential strategies and interventions. Finally, on to E for environment there on our course acronym. So thinking about unsafe behaviours in the home. So, for example, thinking about objects, if you are caring for somebody who exhibits signs of aggression or agitation and throws objects, being mindful about where that person is sitting, being mindful of the objects which are around that person, which are at hand, which they may use to throw. Um, Thinking about technology and assistive technology for monitoring safety in the home, such as door alarms, sensor mats, etc., etc. And then finally, last one of our acronym, onto D for dementia. And these, it's really important to remember that these behaviours are not within the person's full control. And especially if the person is living with dementia such as FTD, the frontal lobes that help manage our impulses, they monitor our conduct and our safety, have been disrupted by the dementia. For people with these disabilities, carers need to help the person maintain dignity by sometimes providing explanations for socially unusual conduct, and also to help regulate that person's conduct and safety. So sometimes carrying cards might be helpful. So if that person is acting aggressively or is irritated in public, maybe saying things which wouldn't usually be said, that you can hand a card to somebody to say, actually, my loved one has a diagnosis of rare dementia, and to explain that behaviour. Okay, so I'm going to just quickly plug about community mental health teams, CMHTs, which are fantastic. The GP can refer you to these services, and CMHTs are often incredibly helpful when managing symptoms of agitation and aggression whilst living in the community. So a CMHT supports people living in the community who have complex or serious mental health problems. So they don't just deal with dementias, they deal with a lot of other mental health problems. Now, care might involve help from one team member, or it might work, or you might work with different team members within the team together. So that could be a combination of a psychiatrist, a psychologist, a community psychiatric nurse, and an occupational therapist, who will create care plans to help manage those symptoms of agitation and aggression. And just as a reminder, the GP will still be responsible for the rest of the medical care, for example, prescribing regular medication, things like that. Okay. Now, something very, very important when looking at symptoms of agitation and aggression, it's looking after you, it's looking after caregivers, because aggression in a person with dementia can be very challenging, very frustrating, and it's very upsetting. And it's important to seek support if the person you are caring for is acting aggressively, and to keep yourself safe. So again, chatting with people living with somebody who has a diagnosis of dementia and is exhibiting behaviours of agitation and aggression. Some of the coping strategies they've suggested is chatting through things, sitting down, having a cup of tea, or going out for a coffee with a friend, a family member, or a neighbour. Taking some time to relax on your own, ask a friend or relative to look after the person with dementia, or use daycare or respite care services so that you can have a break, which I'm going to talk a little bit about in a second. You could also talk to a professional such as a counsellor, a GP, or community psychiatric nurse. You could also speak to a professional at a memory clinic or to an occupational therapist. And if you are caring for a person, it's a great idea to join a carer support group to share experiences and offer mutual peer support. And many carers do find that support groups can often make a very big difference. So, just touching briefly on carers breaks and respite care. So there is a lot of respite care options available. These range from getting volunteers to sit with the person you look after for a few hours to maybe a short stay in a care home. And the person you look after could go to a day centre, or a paid carer could also visit them at home to look after them. Um, your local council or local carer centre can give you lots of advice about local support. And again, just as a reminder, local councils will only fund respite care for people that have been assessed as needing it. So that means that one, there's been a carers assessment, and two, there's been a needs assessment. And I've just put at the bottom there that even if you don't want council funding, it's still massively, massively useful for the person you look after to have a needs assessment, as this will say which type of respite care is the most suitable for that person. So I do urge you, even if you aren't wanting council funding, to get a needs assessment, as this is really helpful in finding out which respite care is the most suitable. And then finally, if you are in immediate risk of assault or injury due to an aggressive outburst, do find an exit strategy. If you're in the community, or equally if the aggression or agitation has escalated and you are very worried, call 999 for assistance. They will provide an immediate response and may also involve appropriate mental health services if necessary. Number two, always inform your GP about aggressive and agitated behaviour. It's important for the GP to know that this is happening, and also to rule out if anything is happening organically to cause this behaviour. But do always tell your GP about aggression and agitation. And finally, do remember about community mental health teams, CMHTs, and how they can help, adult social services, and respite. Okay, lovely. So thank you so much for listening to this talk. It's been lovely to speak to you all. Please do, if you have any questions or would like some further advice about behavioural strategies for agitation and aggression, or equally behavioural strategies for other common symptoms of dementia, such as sexual symptoms, obsessive symptoms, or apathy, please do not hesitate to get in contact with us. You can always give us an email at our contact@raredementiasupport.org email address, and either myself or one of my lovely colleagues will be happy to speak through any issues that you have or any questions that you have.